All right.
Good afternoon, everybody. Thank you for joining. Can you guys hear us? Okay. Can we get a wave or in the chat box say you could hear us?
Hi, good morning, everybody. I'm Dr. Horn.
Dr. V.
This is Dr. V, and we're going to go over common antibiotic regimens and infectious disease pearls. So we thank you for joining us. We've had an excellent turnout with all of our webinars that we've had, and we've had a lot of good suggestions as far as what to go over in the future. So we really enjoy getting feedback from everybody as far as what you want to hear about, what to talk about. So thank you again for joining us. So we'll go ahead and get started. This is common antibiotic regimens, and we're going to go over common topics that we get. So when we talk to people, what kind of things, questions we get, and we like to kind of just review those and see if we can hit some of the highlights. So it's going to be kind of, it might seem like it's all over the place, but I find that it's going to be very helpful. It's going to be like high yield topics, like just the facts.
Yes.
So we'll go ahead and dive right in. This is the IDSA practice guidelines. These are where we get our recommendations. So oftentimes we'll give a recommendation, and then the question will be, where did you get that recommendation? Where did you come up with this stuff? And this is where we get it, the Infectious Disease Society of America practice guidelines. So if you essentially Google the information that you're interested in, so if you Google urinary tract guidelines IDSA, it will pop up and you can see right where we get it. And we're more than happy to send you any guidelines that you're interested in, and we can highlight the part that we talked about if you'd like.
And the really nice thing is everything is free. Anybody could access it. So we love this site, and you get all the latest guidelines. And I think there was a new guideline just released yesterday. I haven't had time to read through, but that's on influenza. So they just released the guidelines on influenza yesterday. So lots of good guidelines here. So, you know, if you ever need to go, there's lots of resources, and it's free.
So every few years, IDSA will update the guidelines, and then there are usually studies that are done that say how good are these recommendations, and if the recommendations help, they keep them in, and if they don't, they get rid of them. So every couple of years they update it, and these are essentially the things that everyone agrees on. So it might not be the latest thing that just came out in the last few weeks, but these are kind of the bedrock of things that we look at. Yep.
And they get a lot of experts, not just from infectious disease, but you know, pulmonary doctors, cardiologists, and depending on the guidelines, they get a lot of input to get the guidelines set. So I think it's again, it's guidelines. It's not, sometimes it's not definitely this is what you do, but it's a great tool, a guide to help you make decisions.
Right, and at the least, we like to follow the guidelines. So this is where we get our information. So we'll start with, what is the break point? So oftentimes when people call us, the question will be, well, shouldn't I use this drug because on the susceptibility report, it has the lowest number? And that's really not always the case. You want to look at which type of infection you're treating, and then see which antibiotic would work for that infection. And then if it says susceptible, it's almost always the drug you should go with.
Yeah, so like you want to look at the disease process, and you want to see which antibiotic works well for this disease process. But you know, especially us working in an academic center where we have a lot of students and stuff. Sometimes they mistake the lower number being the better one. But how it works is, as long as it's susceptible, and they have break points for each drug. Not so you don't compare one drug to like Bactrim to nitrofurantoin. You just look at each of those drugs and their break points, and if they're susceptible or resistant.
Yeah, those numbers only work for that antibiotic. Yeah. So and when we take infectious disease tests, that's what they test us. They try to trick us, and they try to get us to say, well, this MIC is lower than that one, so it should be better for this patient's infection. And that's when we talk to residents and fellows, we say, don't fall for that. Just go for which antibiotic you want to use and see if it says susceptible or not.
Yeah, an example might be like, you know, you might have somebody with like Staph aureus bacteremia, and your vancomycin MIC might be 1, and I'm just making it up. And if your fluoroquinolone MIC is 0.5, but the best drug for MRSA bacteremia is vancomycin and not fluoroquinolone. So, you just have to look at the disease, what drug, and then if it's a susceptible, then you could use that.
So the general rules for interpretation, the lowest number does not always mean the most potent drug. So based on the clinical scenario and the bacteria, pick the ideal antibiotic in that situation. If the antibiotic is susceptible, consider for your patient, does this work for my patient? Do they have an allergy? How is their kidney function, their liver function? And then you kind of decide if that's the best one to use. But sometimes we'll get clinicians calling us and they'll read off all of the MICs. And usually I'll say, does it say susceptible next to it? Then that's the one that would be okay. Yeah.
Please unmute yourself and ask us any questions or type any questions if you have during the presentation.
And then this is the next topic, is busting the myth of static versus cidal. So, and this is common not only with the clinicians we talk to, but also in our practice, kind of day-to-day practice where we talk with the different teams and they'll say, well, for this infection, shouldn't I have a cidal drug instead of a static drug? So cidal is bactericidal, so it means it kills the bacteria, whereas static essentially just keeps the bacteria static and doesn't kill it, but kind of keeps it
under control.
Under control, and doesn't kill it outright. So really, this is something that it's now being proven to be dogma, being something that's in the literature that gets passed on, but the evidence behind it is more of a guessing, and it's more of something that it makes sense that if you're killing the bacteria, then you'd want an antibiotic that kills the bacteria. But when they did randomized controlled trials, it didn't really show to be the case.
So I think, again, the point is using the right antibiotic for the right disease and not worrying about cidal or static.
Yes, so you want to choose the antibiotic for the patient, but not worry about, is this cidal or static? I think, and this is interesting because in medical school, this is something they had us memorize for every antibiotic, and is it cidal or static, and how does that affect the patient? That's why we have to
keep up on literature because everything's changing all the time.
Yes, it does. If you tell physicians this, really they can't believe it because they say that this was pounded into me in school, and it doesn't seem to be the case. So I'm glad they're still doing these studies. I like it when they kind of come out with things that show that what seems to be the case isn't the case. So, okay. So this is a question that also we get. And these questions, they come from the, not only that we hear, but Sumaya has been doing an excellent job. She's the pharmacist that's been working with us, and she's really, we went to her and said, what questions do you get? And this is another one that is another common question. So beta-lactam, beta-lactamase inhibitors have excellent anaerobic coverage. So this is your ampicillin sulbactam, your unicin, and your piperacillin tazobactam, your zosyn. They have very good anaerobic coverage. So you don't need to add metronidazole to that patient to cover anaerobes, since it's already covered with the beta-lactam, beta-lactamase inhibitor. So that's essentially double coverage of your anaerobe.
Yeah, and then we see that a lot too. So there's no need to double cover anaerobes. So, one option is you could do something like ceftriaxone and flagyl, which will kind of have a similar coverage. You could do piptazo and tazobactam, and this piptazo-tazobactam is great, but it also has pseudomonal coverage. So if you don't need that, you could do ceftriaxone and flagyl. So there's other options, but like you said, there's no need to do unicin and flagyl or zosyn and flagyl.
Right, and in the past, when people would do that, it would make sense if they're giving the metronidazole to treat C. diff, but now PO vancomycin is first line.
And C. diff is, exactly.
Yeah, so there were some studies looking at patients that were getting metronidazole unnecessarily, and it was really, they were showing the cost benefit, but it's also beneficial for the patient not to get an extra drug.
And the big thing I always hear from the patients is when they get a flagyl, when they don't need it, they have taste change. So they're not eating well in the hospital. There's lots of side effects with every antibiotics we give. And also flagyl is going to wipe out all your anaerobes that are good in your gut that you want to preserve. So double anaerobic coverage, we don't need.
And then Staph aureus bacteremia always gets at least 2 weeks of IV antibiotics. So this is an important one that we thought we'd touch on. So the default approach would be to treat all Staph aureus bacteremias with at least 2 weeks. So even if it's 1 out of 2 blood cultures positive. So sometimes people say, oh, it's just 1 of 2. It could be just from the skin. It could be a contaminant. And that's true, it might be. But because if it's not, it could be devastating, we would never treat it like that.
Yeah, so like studies show, even if you have just 1 out of 2 blood cultures that have Staph aureus, your chances of having endocarditis is 25 to 33%. So that's what, it's really high. So it's really important to like look at your heart valves and also make sure we treat Staph aureus bacteremia minimum 2 weeks. There's a really nice guidelines too on IDSA for Staph aureus bacteremia guidelines, Staph aureus guidelines, and they kind of lay everything out really nice. So if you ever need that tool, it's on the IDSA website as well.
So, and then Staph aureus in the urine should almost always prompt a search for another site of infection. So oftentimes we'll get called and they'll say, there's Staph aureus, MSSA, or MRSA in the urine. Should I be worried? And what they've seen in the past is that Staph aureus in the urine can sometimes come from the blood. So it goes from the blood to the urine. And oftentimes, clinicians will come to us and they'll say, it started as a Staph aureus in the urine, and then it went to the blood. And really, that's possible, although it's more likely for it to go from the blood to the urine. So we kind of look back and say, have they had fevers? Have they had other things that might indicate that they were bacteremic? So, and sometimes it turns out that we'll get consulted for patients that have Staph aureus in the urine, and then they might turn out to have Staph aureus endocarditis or something that came from the blood. So I would consider, if they have it in the urine, checking blood cultures. And even if they're already on antibiotics, I would still consider checking blood cultures, because it might be that you're really treating a bacteremia.
Yeah, so Staph aureus is usually not a pathogen from the urological area. So it's unusual pathogens to cause primary staph infection. So like Dr. Horn was saying, always think about, did it come from the blood, and check a blood culture and do a little bit more investigation. Only exception is that if you do have a four-way catheter, or you straight cath, or you just had a genital urinary procedure, then it could be a colonization. So there is a small exception. But if you have a 30-year-old that comes in and they're not feeling well, and pretty healthy person, and you get a urine and not Staph aureus in the urine, we need to investigate to see where it came from, because it's not from the urine.
And cellulitis is often initially slow to respond to therapy. So when the patient comes in, gets admitted, gets put on an antibiotic, sometimes the clinicians will expect the next day for it to be looking better. So the cellulitis, they'll demarcate it, they'll draw a line around where it is, and then the next day it could be past that line, and it could be more red, more inflamed, and and oftentimes the providers will say, well, I want to switch antibiotics. And sometimes it could be that it's just essentially inflammation. There's another doctor that we work with that he calls it bug guts. So when the bacteria have a lot of inflammatory things inside the cell, and when the bacteria break apart, all of those inflammatory things come out and causes more inflammation. So it's from the bug guts coming out and causing the inflammation. So the next day it's going to be more inflamed, and then the next day sometimes it's kind of in the middle. It's kind of, one member of the team might say it's looking better, and another member might say it's looking worse. And then by the next day, you usually see some improvement. Yeah,
and some of the cellulitis in patients with like chronic edema, they have a lot of skin changes already. So for patients like that, the redness is going to take even longer to go back to baseline. So one of the tricks that we use is, if somebody has cellulitis, you kind of keep an eye on their leg and see how it looks. But if they actually starts getting wrinkled, that's actually a good sign the edema is going down and the infection is getting better. But with cellulitis, it's usually hurry up and just wait and give the antibiotics. And what we usually do is like see the patients as outpatients And, sometimes some patients might need 7-day course, some may need a 10-day course, some may need a 2-week course. Everybody's kind of different, so it's important to kind of monitor and see, do they need longer, are they getting better?
That's true. So and one of the favorite questions from ID doctors when we ask our residents and fellows, we'll say, how long do you treat cellulitis? And usually we'll get an answer. One resident will say 10 days, the other will say 14 days, and really the answer is until it's gone.
Yeah. Which
sounds like kind of like a trick question, but really all patients are different. So a healthy patient that comes in with cellulitis is going to need a different course of therapy, a different number of days than someone that's morbidly obese, diabetes, peripheral arterial disease, smoker, all these issues. So with those patients, the perfusion is going to be really poor, and they'll need a longer course. And so really we need to treat it until it's gone, and that's different for different patients.
Key is just following them and then just seeing, like, is it resolving? Is it getting better? And extending the therapy. And if it's really good at 7 days, and we gave the antibiotics for 10 days, we could stop at 7 days. Yeah. But I think the trick is just to make sure individualized for each patient and do that.
And those patients, sometimes patients will come in and they'll have heart failure, and their legs will be very swollen. And it's hard to tell, is this cellulitis or is it not cellulitis? And it's even hard for us to tell if it's cellulitis. Yeah. I mean, you have a higher suspicion for cellulitis if it's warm, if it's tender to light touch. But with those patients, and they may not have positive blood cultures. I would say more frequently they don't have positive blood cultures. And when you elevate the legs, sometimes if you can bring the legs really high up, if the redness all goes away in 15 minutes or so, then you can say it's not cellulitis. This is because with the swelling of the legs, it can look very similar to cellulitis. It can be warm, it can be tender, all of these things. So it's hard to tell, and it's difficult. It's easy for me to say that you should elevate the legs, but in some of these patients, that's a very difficult thing to do.
And I think clinically too, kind of making sure that you have a fever, is your white count high, when you touch your leg, is it warm and hot, kind of using those as well. But another thing that we usually find that's really helpful for patients who have chronic edema, they do get cellulitis. Yeah. But then on top of treating the cellulitis, working with wound care and managing the edema is really helpful, because then that's going to kind of control the fluid and not cause all those skin breakdowns too.
Yep. But in diabetics without foot ulcers, cellulitis is most often due to strep and occasionally to staph. So in patients that have a cellulitis of their feet, it's most often going to be strep or staph. So gram-positive coverage. I think oftentimes we're taught we need pseudomonal coverage, we need gram-negative coverage, but cellulitis, the vast majority of cellulitis is going to be either strep or staph, and if you've got that covered, you don't need to expand, you don't need carbapenems, you don't need all of these third-line antibiotics.
Yeah.
No.
And if the patient has never had MRSA, they're not high risk for MRSA. Or, it might be even okay to start with cefazolin, which will cover strep and staph. So it's kind of looking at past cultures, risk factors, but you're right, strep and staph is the main one to use.
And then another topic, we're going topic by topic pretty quickly here. Positive Candida in blood, or positive Candida in pulmonary, so sputum or BAL, doesn't need to be treated. So Candida can be common flora in the lungs, and you don't need to treat it. You essentially can ignore it, and you can not worry about it.
The alternative is if you have Candida species in the lung or sputum, we could just ignore it. But let's say if Candida species shows up in a sterile site like your blood or pleural effusion, or you do a tap in the ascites, and if you have Candida, it shouldn't be in sterile sites, then we need to treat it. But the biggest one is even if you have 1 out of 2 blood cultures that shows up as Candida, we should never ignore that and always treat it as real. Just like staph aureus in the blood, Candida in the blood, even if it's 1 out of 2, it's always real and needs to be followed up and treated.
Yes, and there's sometimes we'll look back on charts and people will say, oh, the Candida was 1 of 2 in the blood. They're not really having symptoms, so that's probably just nothing. And it might just be nothing,
Yeah.
but it could be very serious. And it's something that if it were me or my family member,
Yes.
I would want it, or you,
Oh, yeah.
I would want it treated.
Yes.
So that's something that, fluconazole, just PO. That's another question, but which medications can we give transition IV to PO? And fluconazole is one that gets in very well. It's very bioavailable, and you can give it PO, and you don't have to worry about giving it IV. So this might just be 2 weeks of PO fluconazole for Canada.
Trick to that, you're right, is that just making sure what kind of species, because there are some species of Candida, like Candida glabrata. It's not very common, but we're seeing more and more in the healthcare setting. If somebody has that in the blood, you want to start with the echinocandin, but once you do susceptibilities, then you could go to fluconazole. But if it's Candida albicans, for example, one of the most common ones we see, fluconazole is perfect.
That's right. So for glabrata, mycofungin would be a good one to start with. And then once you get more information about it, you can go from there. So VRE in the stool does not need to be treated. This is another question that comes up. The stool will be cultured, it'll have VRE, and then we'll get called and say, do we need to treat this, or should we do anything differently for this patient? And the answer is no, that's normal flora for this patient. If they have an active VRE infection, it's different, but this is essentially normal colonization.
What I usually tell my students is that in our stool bacteria, it's normal to have anaerococcus, because it's a normal stool flora. So basically what's VRE is this normal anaerococcus we used to have now got a little angry and became VRE and resistance, but it's the same normal flora. So like Dr. Horn was saying, we get this a lot, and not to treat it if it's in the stool, but if it shows up in the blood or lung, that's a different story.
Yes, yeah. And I guess I didn't say, so VRE is vancomycin resistant anaerococcus. So if you find that, if it grows out, you can know that from the stool and the patient's doing okay, that you can just ignore it. Yeah. And then this is an important one as well. This is clindamycin is not reliable MRSA coverage. So clindamycin, and people will say, yes, but I was taught that clindamycin covers MRSA. That's true. It does cover MRSA, but you want to check susceptibilities and make sure that the one that, the MRSA that your patient has, the clindamycin will work.
And they had some, for example, where we live in Nebraska, they had some data with the last year's flu season. They shared it for the whole of Nebraska. And for clindamycin, the MRSA susceptibilities were around like 50 to 60%. But Bactrim and doxycycline was like 85–90%. So it's much better to use Bactrim or doxy and linezolid if you really have to. But Clinda is not reliable unless you know the susceptibilities.
Yes. So if you're treating a patient with clindamycin, so it's okay if you know the MRSA is susceptible. Oftentimes clindamycin is given empirically, and that's fine. We give clindamycin empirically also for patients, but if you know that, and the provider will say, yes, but I'm covering MRSA with clindamycin. Like, I don't know what infection they have, but I'm giving clindamycin for the MRSA coverage. So it's okay to give Clinda, but just know that if you're trying to cover MRSA, it's not reliable.
It's not reliable.
So if someone, and if you know the patient has MRSA, you would want to see the susceptibility report before giving Clinda.
Yep.
So it's okay to give, just as long as you know maybe you're covering it, maybe you're not. Yep. Oh, and then we wanted to touch on double coverage. And usually when talking about double coverage, it's for Pseudomonas. So does Pseudomonas need 2 antibiotics to ensure that it's being covered? And kind of the answer is that it depends. It depends the facility that you're in and the rates of Pseudomonas with resistance in your facility. So if a patient comes in very sick, you want to kind of decide if they're very sick and you know their rates of resistance, but if they're very sick in the ICU or really not doing well, then double coverage is a good idea.
Yeah. Like, for example, what we see a lot is that patients get put on like Zosyn and Levo, and the idea behind it is that Levo is going to double cover. But for example, if you look at the antibiograms that we are used to, levofloxacin and susceptibility to Pseudomonas is like 70%, and Piptazo is like 94%. So you're really not adding anything. So if you're truly worried about a patient that is high risk, who's septic, who's crashing, you want to double cover, you want to give another agent that has high and good susceptibility. So, you know, you could, in that case, you could use aminoglycoside with piptase or cefepime or something like that.
Right, and it's two antibiotics that work different ways. So one is a beta-lactam, which would be the Zosyn, and then you have your aminoglycoside, like gentamicin. So you're giving not two beta-lactams, but two antibiotics with different activities. Oh, and then one more thing with that. Once you know that the Pseudomonas, the one antibiotic will work, you can just go with that one. So if you get the susceptibility report back and it says Zosyn, that it's susceptible to Zosyn, you can continue Zosyn and you can stop the gentamicin, or you can stop the levofloxacin or whatever else you have. Essentially because when you're giving two antibiotics, you're giving two because you're hoping one of them will work. And then once you know one of them works, you can stop the other antibiotic. Bites.
Yeah, so this is one of our favorites, and we get drilled on this a lot, you know, when we take our boards and stuff. So it's so important to know cat, dog, and human bites, and it's always the #1 choice of drug for cat, dog, and human bites. If you eat as prophylaxis, not even waiting for infection to develop, is augmentin, amoxicillin clavulanate, to give that, because there's a high risk for developing true infections if you don't give prophylaxis. So this is the drug of choice. And the bugs we're trying to cover is Pasteurella, Capnocytophaga, or Echinella. So it's, you know, they all have different bugs that cat, dog, and human have, but the drug is amoxicillin clavulanate.
Yes, these are the antibiotics you want to give. Usually the drug that, if someone chooses a drug that's not one of these drugs, it's usually clindamycin, but clindamycin doesn't cover the mouth flora as well as these ones do. So I wouldn't recommend giving Clinda.
No.
Oftentimes people, the provider will say, well, I know Clinda has good anaerobic coverage and I want to cover anaerobes, and they choose Clinda, but that's not the drug of choice.
Yeah, and then if you are allergic to penicillin, there's secondary line. You could use like moxifloxacin with Clinda. Then you have to use 2 different drugs. But you know, where we see a lot of dog bites, cat bites, human bites, usually patient comes to urgent care, emergency, primary care clinic, and it's very important to prophylax them and give them the right drugs. Otherwise, what we see is usually the bites are on their hands, and they develop deep infections, abscesses, and then they need IV and 6 to 8 weeks of treatment. It gets really complicated, so it's really important to prevent that from happening.
Yes, so even if it doesn't look bad, still give antibiotics. And usually ask the residents and fellows, what do you think gets infected more, a cat bite or a dog bite? And I'll give you a second. So the answer is cat bite. So cats have sharp needle-like teeth, and when they bite the skin, because they're needle-like teeth, they can push the bacteria very deep. So it's not just the superficial layers that can push the bacteria really deep, as opposed to dogs that have more blunt teeth. They do more ripping and tearing when they move. So cat bites more likely to get infected, especially so with a cat bite. Even if it looks okay, I mean, if it's on the hand, I mean, I would still give an antibiotic.
And they usually recommend about 5 to 7 days of like prophylactic treatment. So augmentin will be your first line.
Yeah, and we've seen patients that have had dog bites and they didn't have any antibiotics for it and didn't take care of it, and they ended up getting osteomyelitis of their hand. It can be very bad, very serious. If the wound looks bad at all, we always try to get a hand surgeon involved and make sure that, you know, we treat it very aggressively. We get very worried about hands and eyes and certain areas that kind of make us nervous. And then here we have the latest recommendations in the management of C. diff. So we wanted to touch on this as well. Make sure that everybody knows that vancomycin is the drug of choice, the go-to drug for C. diff infections. So we start out now with PO vancomycin, and then only give metronidazole if you can't give PO vancomycin. So PO vancomycin only stays within the GI tract. It doesn't go, you don't get good blood levels. It's not something you would give for cellulitis. You only give PO vancomycin, and if they come in and you think you're strongly suspecting they have C. diff, I would, run the test for C. diff, but also you can start vancomycin just immediately.
Yeah, so that's what we do. If a patient has really bad diarrhea and we think they're high risk for C. diff, if your test is going to take 24 hours to come back, it's better to start the oral vancol to wait for the test, because then we don't want the patient deteriorating. So it's okay to start and wait for the test, and oral vancol is a drug of choice. But also keep in mind, if your patient's recurrent C. diff, always remember about stool transplant as well.
And then that's going to be all for this webinar. We had a question about talking about influenza. That's actually going to be our next webinar. We're going to go over influenza, kind of talk about it for the influenza season and everything. So,
and I think it's really important because influenza, we want to kind of talk about antivirals, and also if you develop pneumonia with influenza, how to treat that as well. We want to open up now to any questions you guys have.
Yes, so if anyone has any questions, feel free to unmute yourself and ask the questions, or type them into the chat bar. I think this was a kind of a good review of the highlights.
Yes, we covered a lot of topics, but if you guys have any other topics you guys want us to cover, happy to kind of go over them. But lots of common questions we get asked about all the time.
Yes, I think this went well. I think we could almost make the top 10, the top 10 ones we want people to know. But feel free to call us anytime. We're more than happy to review these more, or go in more depth, or send you articles or anything that you'd like to go over. I think it's kind of a quick review. So if you'd like any more information, any details about them, we'd be happy to do that.
Wanted to wish everybody a happy holiday and see you guys in the new year.
Yes, thank you very much, everybody.
Thank you.
All right, have a good day.